So Golem, what's going to happen is this. They can flip the screen from my screen to your screen, so you don't need to do anything else. Just leave your presentation exactly like that. As soon as I'm done, our techie people here are going to flip the screen from my screen to your screen.
You want me to more or less bring my
Just leave it like that. Just leave it like that for now. Leave it exactly like that for now.
Okay.
Don't do anything. So as soon as I am done with the presentation, our people will change from my screen to this screen of yours. So that way there's less confusion.
All right, sure.
You doing well?
I'm doing well.
I want to thank you for waking up early in the morning, taking the time to
well, that's once in a lifetime. It's not going to kill me, hopefully.
So I think it's almost 6 o'clock, and we're going to go ahead and start the Anand Institute sponsored program. I want to first of all thank everyone for coming here and all those people who are watching this show on YouTube. Welcome to Anand Institute sponsored program as part of the TOS, or Telangana Ophthalmology Society. So Golem, for your information, Telangana is a pretty large and rich state in the southern part of India. And the capital city, as we discussed last night, is Hyderabad, which is where this meeting is being conducted. And TOS leadership is right in front of me. They are, fortunately for us, and they all want to hear you, and they gave us permission to go ahead and host this session. So thank you, TOS. Those are my financial patterns, whatever it is, but nothing that I'm going to say has any effect on this. So on behalf of Anand Institute, I want to welcome all of you to 14 years of Anand in the state of Telangana. And welcome to our 14th annual Foundation Day celebrations, which is being sponsored, or in one way, being part of the Telangana Ophthalmology Society. And a big thanks to our sponsors, Intas and Cipla Pharma. Without pharmaceutical industry support nowadays, we can't host these kind of meetings, large-scale meetings. So today, what I'm going to do is to cover surgical glaucoma timeline briefly for the next 15 minutes, followed by my introduction to Dr. Gholum Peyman, who's online. He's waiting for my talk to be finished, and then I'm going to officially introduce you to our visiting professor for today, Dr. Peyman. And then Dr. Peyman is going to go take you through his multiple inventions and the thought process that led him to do his innovative work throughout his career. So here is your glaucoma timeline. We started off with iridotomies iridectomy actually in 1850s all the way to 2020, where MIGS has become the main theme, and you heard many presentations today. So the original inventor in glaucoma in my mind is this guy here, Albert von Grafe, who invented his famous graphene knife. Many of you may not have used it, except for old people like me. As a medical student, I attended eye camps. I used the von Grafe blade to do the intracapsular cataract surgeries. That's one of the ways that I got myself interested in ophthalmology. So a lot of people in Europe came to know about von Grafe, and they all used to track him, including those patients with absolute end-stage glaucoma, with severe headaches and stuff like that. And so von Grafe famously put his knife into the eye and unknowingly created an iridotomy. And that resolved the headache in some patients, and in some patients it did not. What he didn't know, and he had to wait for another 60 years to know, is that glaucoma is of two kinds, open angle and closed angle. Those with acute attack of glaucoma, he was able to help with these iridotomies. Those with end-stage glaucomas from other reasons, with the high pressures, they did not respond. But in the recorded history, the first surgical treatment ever described to our knowledge is von Grafe's iridotomy. So thank you to him. Trabeculectomy is an age-old procedure, as you all know. Came out in 1960s. modified it by Kane in England. And as you all know, it directs the aqueous into the subconjunctival space. Subconjunctival fibrosis is what leads to its failure over a period of time. But a well-done trabeculectomy is always a pleasure to watch. I know a lot of people are giving up on trabeculectomy, which I think personally is a mistake, because there are quite a few patients who deserve trabeculectomy to achieve the kind of target pressure that we need in these patients. And in around 2000, the express mini shunt was introduced into the United States, where the initial statement was lift the conjunctiva, stick the express into the anterior chamber, and close the conjunctiva. A lot of those patients ended up with complications, including choroidal effusions, hemorrhage, and exposure and erosions. And we wrote one of the first papers when I was there. Dr. Peyman was also one of my co-faculty at that time. He doesn't know this, but he was a mentor because I read his old books, and that was a great pleasure to have him as a co-faculty at that time. So anyway, in any case, based on our paper, they modified the surgical technique and converted that into a mini trap kind of a deal where they would put the express under the flap, and the success rate is about the same as a trabeculectomy, but at $700 more expensive glorified trabeculectomy, if you like. Now, how about Zen gel stent? I don't know if it is available in the United States. This was introduced in 2016 in the United States, this is beautiful technology. Literally in 3 minutes, you can do the surgery. Initially, it was introduced as ab interno, and later on converted into ab externo technique. And you can see this is unedited video of how to insert the Zen. Essentially, this is a microtubule, 43 microns in a diameter that diverts the aqueous out into subconjunctival space. And the big problem, anytime we do any subconjunctival diversion, is fibrosis. So all it takes to cover a 43 micron hole is what? A couple of fibroblasts. So a lot of these Zens do fail, and so extensive use of mitomycin needling and all of these problems are there. Watch this ab externo technique, which is so cute. Real-time, unedited video. All you do is this. And name a glaucoma surgery that is as quick as this. You go in and then inject it into the anterior chamber, and 1/3 of the device goes into the anterior chamber, and 2/3 stays under the subconjunctiva, and then you inject some mitomycin around it, and you're done. Pretty much. Great. But post-op management is the key, as in every glaucoma surgery, and the problem with this is exactly that. I did a lot of Zens back in the day, and then I gave up. And the reason why is this high failure rate. At exactly 1 month, a lot of these attracted fibroblasts and fibrosis around that opening of the Zen, and a lot of these started failing, and this chair time of manipulating these Zens at the slit lamp really was not worth my time anymore, so I quit doing Zens. But I think some modification of slow-release drug delivery systems into the future is going to revive surgeries like this. How about blood revisions? When a patient with a failed trabeculectomy comes to my office as a referral, the first thing I do is blood revision right then on that particular day at the slit lamp. And it works great. I mean, almost 50% success rate at the end of 2 years. What more can you ask for a 1-minute procedure with a 30-gauge needle done at the slit lamp? It saves money for the patient, it saves a trip to the operating room, and you're giving them a 50% chance of successful blood revision and pressure control. Watch this, nice blood is formed, and then I inject mitomycin. You got to be careful when you inject mitomycin at the same time. You don't want mitomycin to track into the anterior chamber. It will destroy the iris and the corneal endothelium. How about acute angle closure glaucoma? You know, traditions suggest that you got to give them IV mannitol, IV Diamox, and drops till the pressure comes down and the cornea clears up. 20 years ago, I quit doing that. When the patient is referred to me with acute angle closure glaucoma with corneal edema, all I do is to betadine prep, lidogel, lid speculum, put the patient at the slit lamp, 30-gauge needle goes into the anterior chamber. Within less than 30 seconds, all it takes is to drain out 2 or 3 drops of aqueous, cornea clears up. You can see a close-up shot of the cornea clears up, the pressure drops down, patient is pain-free, then you do everything else that you want to do. I then take the patient for organ laser iridoplasty, followed by within a week or two, cataract surgery. And I do the same thing, when I say same thing, I do the cataract surgery without waiting to the fellow eye, even if the patient is asymptomatic. This is one kind of glaucoma where I can confidently say, hey, I cured you, I don't need to see you ever again. So this idea of following up the fellow eye every 3 months over and over again, I think that's all unnecessary in my opinion. Now, 2010 to 2020, fast forward, we are in the mixed era now, microinvasive glaucoma surgery. Do you know the guy whose picture is being displayed? That's Frederick Schlum. So he was an anatomist back in Germany, Austria, in 1850s, around the same time that Von Graffi was practicing. And back in the day, if you want to study anatomy, you have to dig up dead bodies. And he was caught and he was jailed. And lucky for us, after he came out of the jail, the chair in Berlin ophthalmology department took him as his faculty. And with the instruments that he had at that time and the microscope that he had, he was able to identify and isolate 150 to 200 micron Schlemm's canal. Now that's dedication for you. So with that, we have lots of people who worked on these mixed procedures. That's Ike on the left side, then Malik Kahook, who used the Kahook blade. We saw many presentations of that today. Richard Hill is the guy who thought of the eye stent, made that into the company Glaukos. And David Badawi, you may not know him, but he's the guy who devised this Omni system that does ab interno canaloplasty viscodilation. So these are all great inventors. I like to show this to all my residents so they can start thinking about this kind of procedures. So mixing mix, we heard a lot about this in my morning talk, and Vanita also showed several of those videos. Mixing mix is a great way to control not only mild glaucomas, but moderate and advanced glaucomas. But be aware that you may not achieve the target pressure and not be resistant to do a trap when and if necessary. So that's my only caution to everyone. Different kind of mixed procedures that I'm showing here. How about micropulse with cyclocryo? We published one of the largest series of 270 patients with micropulse back in the day with a lot of my fellows from Tulane. It's effective in about 70% of the patients with mild primary open-angle glaucoma. Secondary glaucomas, its efficacy is not so good. So it's not something that I rely on. If I really want to use something cyclocryo, cyclodestructive, I go straight to the old-fashioned 1970s technique, cyclocryo. You should know your limitations when you're using the cyclocryo. Never exceed more than 150, 180 degrees. Use only 5 spots and repeat it maybe once, and that's about it. And usually you get much better results with that because there is ciliary body destruction with this technique. With the retrobulbar bar, you can do it in your slit lamp in your clinic. How about the glaucoma drainage devices? Anthony Maltino was the one who took his professor's advice and converted a straight tube into the modern plate and tube device. And this is in 1969 that he started implanting his implants. And then George Borwelt came around and expanded the size of the plate, thinking that bigger is better. And Mateen Ahmad, who's originally from Lucknow, and spent some time in his childhood days during partition in Hyderabad, and a good friend, he invented the Ahmed valve as part of his thesis during bioengineering PhD in New Delhi, in Delhi University, back in the day. And then he immigrated to the United States, and like they say, rest is history. Dr. Peyman also has a patent on a glaucoma drainage device. By the way, I don't know if he's going to share that information or not. I'm just throwing it out. And he had a device designed that he published upon. So in glaucoma drainage device in 1969 to present, the key findings, it's all 30% failure rate in 5 years, 30% exhibit hypertensive phase, 30% corneal decomposition in 5 years because of nutritional deficiencies, what I believe, oxygen and nutritional deficiency, and tube erosions, infections, and post-op fibrosis. So whole bunch of variety of devices are now floating all over the world. You got to pick and choose the one that you think is appropriate for your particular patient. So what in 2020, what is the next thing the big thing that's going to hit glaucoma? I think it belongs to slow-release drug delivery systems. And here are some examples of it. Durista, somebody spoke about Durista in the morning. It's a very simple PLGA-made device that has bimatoprost loaded into it. And that's it. That's real-time, unedited video of injecting the Durista into the angle. The theory is that it's going to stay in the angle and release the drug over the next 3 to 6 months. Unfortunately, the problem with Durista is that the PLGA stick that you just saw can float up and cause corneal endothelial damage. So the phase 3 studies have been put on hold right now of repeating the Durista. 1 is safe, 2 is questionable, 3rd one, they don't want you to do it anymore because they're noticing more and more endothelial cell loss. So we, and even though it was one of the first FDA-approved devices, and it's a great, I think, path forward for us to follow, this may not be the one that is going to hold into the future. So you have this now iDose introduced by Glaukos, where there's travoprost inserted in there that can release the drug for 3 years. And now you're talking about telling the patient for the money that they're spending, at least for 3 years, patients with ocular hypertension and mild glaucomas, they can get rid of the drops. So I do believe that this is something that I will be using. In fact, when I go back, I probably will be doing my first iDose. We just got FDA approval in the United States for iDose, but it costs $13,000. Ouch, right? That's a lot of money. So with that, I conclude my talk. I want to give more time to Dr. Peyman. What can I tell about you? So at the very outset, I have to tell you that even remotely, Dr. Peyman was my mentor. He does not know this. When I was studying ophthalmology here in SD Hospital, I read his 3-volume textbook. That's how I knew there's somebody called Gholum Peyman. And not only me, all the colleagues that I trained with, everyone mastered the 3-volume textbook of Gholum Peyman. And that's a lot of them. You know, a lot of people, Gholum, I just want you to know that a lot of people in the audience are raising their hands. They all read your 3-volume textbook of the practice of ophthalmology, and I think we became reasonably good ophthalmologists, you should say. So to go back to my slide, please. Let me do my introductions. So he's a professor currently in the University of Arizona Medical School and then to Tulane School of Medicine. This is a man who has got more than 1,000 publications, more than 1,000 presentations in national and international meetings. He's a fellow of the American Academy of Ophthalmology, incredibly talented retina and uveitis specialist. He won the National Medal of Technology and Innovation. There are only 2 more ophthalmologists who ever won this national medal, Presidential Medal of Technology and Innovation. The guy who invented phaco, and more recently, the guy who invented OCT. They both got it, but Dr. Peyman is the only living person that I know. I mean, I don't know the guy who invented OCT personally. He's practicing in Case Medical Center. So he's also credited as the inventor of LASIK surgery that you all do, take pride in. Dr. Peyman holds a patent on it, is the inventor of LASIK. He's a fellow of National Academy of Inventors, 100+ patents, numerous awards. And if you have not met a genius in real life, here is your chance to meet Dr. Peyman. He's a real life genius, my mentor, and Dr. Peyman. There you go.
Thank you very much.
It's all yours.
Thank you. I don't think I can say anything after you finished. Anytime, basically, to repeat these things are not necessarily any more helpful for me, but I would first of all like to tell you that from my point of view, I don't know how I came to ophthalmology at the beginning, because that was not my goal in life. And that's why I brought the title of Life, Destiny, and Serendipity, because my father was a general practitioner and also was basically doing everything himself, you know, pharmacist and all the other things. And my grandfather was also a doctor, but I really didn't want to go to medicine, in fact, at the beginning. So I just said that life, destiny, and serendipity because when we start someplace, we never really know where the end is. So that is how also my destiny is. Now, first of all, I would like to really thank all my colleagues in Hyderabad. This has been a city I've mentioned that I always wanted to see, but I never managed to do that. I traveled to India at the beginning when I was younger, many times to Madurai, but unfortunately I didn't see anything else. So I came to Delhi and also Bombay, but life is too short. One cannot see everything. No, I thank Dr. Ayalov and also the rest of all my colleagues there for their invitation. I'm really honored by this invitation. I think, I don't know I can add anything to what you guys have been doing, but Dr. Ayala wanted me just go over some of the past things that I've done.
So Gholum, can I interrupt you? If you can go to the slideshow on the top.
Yes.
And on the top, go all the way to the top. Put the cursor on the top.
This one?
Keep going to the top, on the red line, red border on the top. And in the middle, you see slideshow. And click on the slideshow.
That's a slideshow, okay.
Keep going up. Yeah, keep going up. Keep moving the cursor up.
Okay, I can actually bring it up like this. Is that okay?
Yeah, you can click on that too. Yeah, click on that.
Okay, how about this one?
Yeah, there you go. Perfect. Now you're full screen. Thank you.
No problem. Okay. All right. I began basically. I was born in a small city, but beautiful city, Shiraz, in southern Iran, and then I traveled also to Tehran at the end for my finishing high school. And then from there, I was didn't know what to do in engineering or medicine, but my parents insisted I could do the medicine. So I applied for a position at the University of Freiburg, and I'm just going to fast through these things just to give you an idea of what happened to me. And this is the University of Freiburg. It's just beautiful city here in southern Germany. And then after finishing medical school, I went to a year of fellowship in Passaic General Hospital in the United States. And then came back and was really basically didn't know what to do, and I decided to go to ophthalmology. The beautiful part that I was accepted as Düsseldorf with Dr. Pistolis, who was one of the pioneers in retinal surgery. And while I was there, I heard also that Dr. Meyer Schweikrat in reality became the chairman of the department, and he was the person who invented the light coagulation, as you see his picture here in this lower part. After finishing my residency, I became actually in charge of the retinal section at the University of Essen. But I was still in love in coming to the United States, finding out if there are other possibilities, because I could not do research in Germany because there was no facilities available. And it was really not that much also appreciated, sorry to say that. We didn't have a laboratory, so I thought maybe at least for a year I should try to come to the United States, and I applied for it, and I got the Jules Stein Eye Institute. 1970, I started there in the middle of the year or so. But it was a wonderful experience because I was seeing patients during the day, and in the evening I had the options of really doing research by myself, and sometimes also some people helped me in that. And so I started doing a lot of things myself in the evenings. After finishing my fellowship, by chance I met Dr. Goldberg in a bigger meeting that they had in Orwell. And Dr. Goldberg asked me if I was interested to come to Chicago. And he had started the year before, and he was the chairman of the department. He came from Johns Hopkins. So I said, yes, I'll be glad to come over there. And I went there to give a talk. And I gave a talk on basically some instruments that I at that time had developed. And I'm going to talk about it later. Now, but he left in 1986 to go back to Johns Hopkins. He became the chairman, and I decided in that moment that maybe it's time I should go some other places. So I came to New Orleans, started joining LSU initially, as you see on the top, and then subsequently joined the Tulane University because the chairman of the department knew me. I knew him for a long time, Dr. Caldwell. And Dr. Ayala knows him very well too, and he was a very fine gentleman. So I was at Tulane for maybe over 5 or 6 years, but at that time, 1950, unfortunately, we got the Hurricane Katrina, and as you see in the middle lower picture here in that area, I don't know if you can see that, but there you see all the houses are underwater. So when we finished, my lab was completely gone, basically was flooded with water, and there was no animal to work with, nothing. So I decided to talk to Dr. Caldwell, and I thought, he said, maybe it will take at least 10 years to more or less repair the situation, so it's better if I accepted another place you wanted to go. I said, fine, I applied, actually. We got an offer from the University of Arizona in Phoenix, in Tucson, so we started the year there, and after that we moved to basically in Phoenix area. Now, all the time I've been in charge of the vitreoretinal surgery, but I never really limited my investigation to the vitreoretinal. And for some reason, I've been interested in solving the problem. And that's why also I was interested in other fields simultaneously, so that is the reason I do other different things, because somehow my mind is working differently and it doesn't stop in one place. So I apologize for that, but that's how it is. So I was at, as I said, at the University of Essen. When I was there, I became in charge of retina, in fact, during my fellowship. And I noticed that I could not really do the research there. And the first thing I wanted to evaluate was the blood-ocular barrier, because we were doing the laser light photocoagulation on diabetic patients to actually prevent them to grow this neovascular tissue, which was absolutely wonderful and worked very well, in fact. So in fact, other people from other cities or countries would come and visit us, and I would teach them how to do the laser light photocoagulation. So one of them was this, and that is a part that I started doing when I came to the United States. And what I was interested in to find out how I can look inside in the eye and see the structures and so to see what is the blood-ocular barrier and how I can look at that and say what is the effect of laser actually on that. And that was my incentive to find out what is the blood-ocular barrier altogether. We had not really learned from it at all, not much of in the literature in that time. So I started looking into that and wanted to find a tracer material, which I found in the form of peroxidase, which is a dark material. It can be injected, obviously not for human, for animal inside the eye or in the circulation. It travels inside the body and through the circulation and comes out. And I'm going to show you pictures how these things happen. And I also wanted to know what happens when I use peroxidase simultaneously after doing photocoagulation. And here are the results, actually. After injection of the peroxidase inside the vitreous cavity, I noticed that the peroxidase rapidly passed through the retina, very fast. In fact, all these dark areas, these outer segments in this area, passed through it and reached that. And interestingly, it came out to the, how do you see on the right side, the retinal image of histology, and then also electron microscopy. Now, the top here are the outer segments of the photoreceptors, and the bottom is the retinal pigment epithelium. So I noticed that, as if you can see it, hopefully, that the peroxidase came out and stopped here at this junction. This junction is, in fact, something that we know about, this junction between the retinal pigment epithelial cells. So that is a barrier, actually prevents anything to come out from the inside the eye outside. So this was very interesting for me to know. And then I injected the peroxidase intravenously and see what happens to that. And I noticed that this is the back of the eye, and you see here the retinal the choroidal capillaries here, and they have opening in them that permits actually the peroxidase to pass through it and then come out. When they come out, they also stop, and when injected into the circulation, comes out in the retinal capillaries too, but it doesn't get out here, as you will see it here. So when I look at the peroxidase, which is a dark material in the back of the eye, notice the retinal pigment epithelial cells here, the barrier is here. So that means anything we inject inside the circulation doesn't really get inside the eye. And therefore, I felt that it's almost impossible to treat the diseases of the retinas only by treating it systemically. It's just not possible, especially if we are talking about the infection. So after the laser photocoagulation, the effect was so that the barrier was partially broken, not completely. But what interesting was that the circulation was actually more toward the outside rather than inside. As you see, that peroxidase passed through the scar tissue and gets out, but when we inject it in the circulation out in the body, not much comes out inside the eye. So most of the circulation direction is from inside outside if the barrier is broken. And that was really interesting for me to look at the effect of laser photocoagulation to interpret it, what happens with diabetic retinopathy, because I had to deal with this very long time. At the beginning, as I mentioned, that we had the light photocoagulator first time in the world, and we were working on it because Dr. Maheshwar had invented that. And then you see diabetic retinopathy causes a lot of damage to the retina, and especially macular edema is a very common situation, and that people who have that, they cannot really see properly. 50% of diabetics have this problem, and this can be actually treated either locally by local administration of the laser, or in fact, you can do it by retinal photocoagulation, and the way we did that. And it was made a stable condition of the retina for a very long time. And as you will see, I had these pictures here. And that was interpretation for me that really, when we break that barrier, the fluid and materials that normally can accumulate inside the vitreous cavity and cause all of the, and excites the neovascularization, also bleeding, can hopefully disappear and do the job. And in fact, it did it. But the second conclusion I draw out of it is that what happens with the infection processes that we have when we have blood-ocular barrier. In that situation, majority, unfortunately, medication that we inject inside the circulation here, as you see it here, they cannot pass the barrier because we have these intercellular spaces that are blocked by the zonal occludentus, as we call that, and the medication doesn't really reach the retina. So this was just a wonderful study I did with collaboration with some of my people there at UCLA when I came here, and I was very, very pleased with that. As you see here, then I drew the conclusion that for endophthalmitis, afterwards, 1971, when I got to Chicago, and I was in charge of myself for that section of the retina. And I did start doing investigation on this, and in fact, by chance, I had operated on 12 rabbits on the retina because I was doing it lensectomy vitrectomy with the new machine that I had developed. And all of them got infected, and that was just disaster. So I came out to the conclusion that, yes, we cannot actually treat these animals anymore by systemic administration. We have to start doing the toxicity study to find out how much and what material, what medication we can do that. That started 1971, and after, and you will see it here, the medication was injected. We did a lot of first experimental study to establish the non-toxic doses, because obviously it is very important to do that before that. And the medication had to be injected mostly in anterior part, because the concentration of medication injected, if it is injected in the back of the eye, here in that area, actually can be toxic potentially in some situation. Obviously it depends on the concentration, but I think it's better to inject it toward the anterior chamber rather than posterior chamber, because we don't need in reality to inject a lot. Now, all these eyes and rabbits and other things were evaluated by histology and electron microscopy and electroretinography. So we see that experimentally when we treated the eyes, the animals, by systemic medication, practically, unfortunately, a majority and all of them practically got infected, and we had to sacrifice them. And then we found out that with those that we injected intravitreally, for that matter, majority of them survived. Now, the first things that I did, I got the fellow from India, Dr. Malzami. At that time, he was also a fellow in Chicago, and he asked me if I could actually come to India, and that was really the first thing I ever did. And I went there, and I will tell you now the result of some of the studies that I did with another colleague of mine, and Dr. Sattar is also from India, and we did it on eye bank eyes. And here I did the studies in reality, looking backward and seeing from 1961 to 75. At that time that when we started, 50,000 patients were operated without really prophylactically, except for using chloramphenicol, topical prophylaxis. But these things don't do much at all for the infection. And they found out that the incidence was about between 3 to 6%, depending on the eye bank and the procedures, more or less sterility, maintaining it, which is sometimes very difficult to do that in the eye bank when you're dealing with hundreds of patients. In fact, I was there and participated there. Now, we're actually injected only 50 micrograms of gentamicin, which is one of the first things that we evaluated. That's a very low dose, and in fact prevented the more or less incidence of endophthalmitis to be so high, the incidence reduced to 0.37%. And this was published by us, including Dr. Sattar, in British Journal of Ophthalmology, the first time in 1977. At that time, even in England, people were not really using any prophylactic application intracamerally or intravitreally. So that's why I introduced it in that time. But during the next 35 years, and it's a lot of work, I evaluated practically all the antibiotics that existed at that time, as much as I knew were available. We did all evaluation toxicity, they are available, and the list of those things have been published also in this publication, which was in 2009 Retina, and we can find out under my name and also my colleague, Dr. Matregi. And also we found out that obviously, similarly to for infections, we should be able to use it not only for bacterial infection, but also antifungals and antivirals. We did all the studies. In fact, some of the very first studies for the AIDS and other things was done in my laboratory. in Chicago by injecting it to save their retina from the infection from AIDS infection. So, and also included anti-inflammatory agents and in diabetic patients and uveitis, and including the gene therapy. The gene therapy probably the most effective is applied intravitreally or subretinally. And also subsequently, the last experiment I did on this subject, intraocular injection, was evaluating the non-toxic dose of elastin, which became available in 2004, 2005, when I was in New Orleans, and the study was done. We did a non-toxic dose of that, and my colleagues in Bascom Palmer have not really done the intravitreal injection. Dr. The only person that did, I think, was mostly in California, and so they did that independently. Also, toxicity study, similar results we found out. So basically, intravitreal injection is a process that's accepted by everybody. An incidence is probably more than 10 million a year in the world nowadays. So that is really one of the interesting things that contribution that we did, my people in my laboratory, a lot of fellows who worked with me. The next thing that I was interested in while I still was in IS in Germany was because I became in charge of the retina section in that area. And I was frustrated when I had diabetic patients and we could not treat them. So I thought maybe we should actually have developed something to be able to remove the vitreous and the blood from the eye. But then at that time I got the offer to go to Chicago, to Los Angeles, Julius Stein Eye Institute. And with help of one of the employees there, I developed the first vertically oscillating system. Now, this is independent from what Dr. Markner did, which was working at Bascom Palmer Institute at the same time. And he developed a rotary system, which was constantly rotating back all the way. And I didn't think that the rotary system would be really something that would work, because if unfortunately the vitreous would be stuck in that inside and the rotation occurs and it would pull it and pull the retina off. And it happens really, that happened, they dropped themselves later, that concept too. Later, Dr. O'Malley contributed a lot in making a system which separated from each other, but my concept initially was one single unit with oscillating back and forth motion vertically, and also simultaneous delivering also the fluid inside the eye where we were operating. Around the same time, as I mentioned, when I was in Chicago, Dr. Lamprey Malzani was there, so he invited me, and in fact, this is one of the first years I developed. It's called Peyman Vitrogauge. I actually told them a company to bring out, and they donated this unit in 1974, and I established a meeting, and a lot of people from other parts of India came here, including Dr. Badri. His picture is not here, unfortunately. I'm very sorry that he passed away last year. He was a very fine gentleman, very philanthropic person, and I missed him. This is Dr. Venkateswamy, who actually was the initiator of the entire development of Arabian Hospital. So, and that is to the left side of him. That's me when I was much younger. So basically, in addition to being interested in the vitrectomy, we felt that we needed to modify the rollers, the machines that we were working, microscopes, and for surgery, because the assistant could not see hysteroscopically through the side of the patient. The operator could see it binocularly, and she had a hysteroscopic view. So I modified the system and developed this called a three-dimensional images converted to three-dimensional, really basically by having additional, the same system without changing anything. So the assistant can also look through two binocular using the entire thing, but getting four basically views inside the eye and seeing similarly the stereoscopic view for the assistant. With all of that, unfortunately, none of the companies wanted to do that, despite the fact that they got a patent on it. But as soon as my patent time ran away, everybody, nice company, German or non-German companies developed this instrumentation. In fact, for all the instruments that we are working in this one, there are binocular system for both system, for the assistant and for operator. Simultaneously, during the surgery, I developed also the laser for coagulating when we got a tear in that and bleeding occurred, etc., etc. And that was one of them. And another colleague of mine developed laser, not laser system, a xenon coagulator, Steve Charles, in the United States, but the laser system is better because it's not absorbed by the wall of these tubes, and therefore doesn't really cause coagulation. So I think everybody gravitated toward using the laser in that way. And then we wanted to also visualize the structure of the vitreous cavity because it was be operated very often, and we could not see this structure very well because the vitreous is really clear. So we decided with Dr. Conley actually to inject triamcinolone inside the eye, and we see this technique by pulling the retinal membrane, epiretinal membrane, in fact separating it, or in fact the internal limiting membrane. As you will see, we can separate it nicely here, and basically then we know what we are taking off, and we're not worried about tearing the retina when the things are coming here in front of us. And obviously we can go by later and do the rest of the surgery. Now the last thing that I was interested in still, in fact I started when I was in Germany, was the resection of intraocular tumor. I was interested in see if we can remove that. And when I came to the Julius Steiner Institute, this experiment was done in animal, 1971. Basically, I took a part of the wall of the rabbit eye and replaced some with our tissue adhesive, put it down, and then you will see it here that inside, looking inside the eye of rabbit, you can see that area that are basically cut away. And that is the combination both together. So I called it IO resection, 1970. When I joined the University of Illinois, then we developed patients, removal of these tumors, a number of these things. And so did my colleagues in Spain, Dr. Garcia Rumi, who picked up also similarly. Then after that, I entered the vitreous cavity, and I thought maybe some of these things maybe can be done under a retinal flap, which actually worked much better because you could take the flap off and do that, especially if they were posterior located, and then remove that tumor, and then also put the flap back. And then you should not do the air fluid exchange because the air would actually get into the circulation and cause air embolus. Yes. It would replace them, the fluid would be replaced by the saline solution, no, by the silicone that will stay there. And with all the B3 and force up a few patients that I thought this would be of interest to see how it looks like. Obviously, with the small tumors, maybe its resection is really okay, fine, but also similarly, I don't think that radiation is bad. In fact, the helium, ion radiation, they are all working very well. So they have small tumors and they can be treated. Unfortunately, they can have some side effects of post-treatment damage to the retinal circulation, and then nowadays you can treat them also with anti-VEGFs. The first retinal biopsy obviously was done while I was doing work in Chicago. And we wrote also a number of papers, among them with the collaboration of my colleague, Dr.Gholum and Dr. Sanders. We worked on the 3-volume book of Principles and Practice of Ophthalmology. It became very famous in India. I did not get much of credit for it in the United States, but I owe that to my Indian colleagues because they really liked that, and it was a simple way of reading it and understanding it. So at that time they were not really, except Duke Elder had written 10-volume book, but it just was much more complex, and it could not be really also repeated. So that was the first time. But then how did I get to get myself into the LASIK surgery? And this is really interesting too, because I was in the lab down in Chicago, and I was a resident came out and asked if he could work in my lab, and if I had a project. I had in mind actually to do something with the lasers on the cornea, because till that time no treatment, no laser was applied in the cornea, because the laser that we had at that time, in the 70s, basically, they were passing through the cornea. They would not be absorbed, because argon, neon, or other lasers that we had available, became available. They would not be absorbed by the corneal tissue, so there would not be possible to modify corneal refractive error by them. So I decided to ask one of the colleagues who was working with the CO2 laser in the ENT department, where I was also the same place, was a nice gentleman. I asked him if I could borrow his machine. So I borrowed it for a week and I brought it to my lab, and we started looking at it up, really basically ablating the surface of the cornea. And you will see here that in fact, if the thermal energy is absorbed by the cornea, then your corneal modification is possible. That's what we did. We found out that in fact we could now, at that time, with the CO2 laser, but I never felt that the CO2 laser was really good for anything on the surface, because it would create only burns, and it would not do quite the way that one would like to do it. And this paper was the first time ever anybody published in the effects of lasers on the corneas. There might have been also some people got a simulated subsequently to do that. But anyway, my conclusion was that doing under the corneal flap was in fact better, because it eliminates the pain that the patient feels after surgery, and it's not the external procedure, it's just covered it by the flap that we can make it. And then also potentially prevents also infection, because then the surface of the cornea is not exposed to infection by infected bacteria. And it also protects the operative field, this flap. So that's what I had in mind. If I could get hold of a machine, one day it became available. And it was not there until Dr. Srinivasan, who is also in India working in the IBM laboratory, developed an eczema laser and they published it. They had done actually this ablation on the hair, which you see a wonderful hair presentation, and that was credit goes to Dr. Srinivasan who developed it. And he was one of the first, one of the people who also with me got the National Medal of Technology for developing the eczema laser. And I got it because I had the concept of using it and for ophthalmology modifying corneal refractive power. My colleagues were in that close to the IBM laboratory. They started using it as a radial keratotomy, as an RK, making incision with the CO2 laser, but it was really not kind of I felt that it was not for that reason. Then later they switched to PRK, doing all their surface ablation, but still I had the same idea as before, and I thought I could, but I could not get access to the laser, so I talked to one of my friends, Dr. Gierkowski. He told me that I should come to Finland. So I went to Finland, and there I went to the University of Helsinki, and we did the studies there. I brought the eyes with me, in fact, and I looked at the various excimer lasers. And I see the examers to find out which one is the best suitable for the cornea. And this is xenon examer laser, and then was krypton, as you will see, they all creates a little bit shrinkage and effect on the corneal stroma, except for the argon fluoride laser that created very smooth edges here, as you will see here. So this is the first experiment that ever was done. But the purpose was actually to be able to still to do these things under the flap, not on the surface, because I felt that the surface was not necessarily that good thing to do. So maybe I was wrong in it yet. The PRKs is still viable procedure in my opinion, but it creates quite a bit of pain initially till the surface of the cornea is epithelialized. So in 1985, I filed for a patent, and the patent was issued in 1989. And then the Vizix company became available, and they actually indirectly got my patents and they developed all this machinery. Now, for doing the corneal flap, the people got excited about it and developed also actually a microtratome, or later, better technology became available to using a femtosecond laser. As you see here, the femtosecond really goes under the cornea where you want, inside the cornea, and makes this flap. And then you can actually do the laser here on the surface of the stroma with the examer laser, and then you can subsequently put this, sorry, this to go back, and then the flap is turned back here, and you see you will have a nice smooth surface on the surface. It's very important here. That's how people love the basic surgery, because they can get up after surgery, and then they can see immediately. So this is not many situations that one can do that. So that's why people, and also the LASIK surgery is much more accurate than smile procedure altogether. But I think a smile procedure is a good procedure too. But it has limitation because you have to also remove certain amount of tissue from inside the eye. So the limitations are still applying there, because the limitation of the LASIK is about maximally 7.5 power to avoid the corneal ectasia. So that was a short, the LASIK surgery has become very common for already more than 5 million people in the world now being done with that. And I'd like to finish this now with thank you for invitation. And just wanted to show you how we proceeded over the years and what happens to one project that we started. Unfortunately, a number of these things we were successful and patient benefiting. I appreciated all the collaboration that I have gotten from Dr. Ayala and everybody else when I was working with them together. And also, I really appreciate that they have invited me here. Hopefully one day we will meet each other either there or back here in the United States. Thank you very kindly. Well done.
Gholum, I want you to know that you are a source of inspiration to generations of ophthalmologists. Okay?
Thank you.
You're the only genius that I've ever met in my entire life, a living genius. And I'm so grateful. I still remember the first day I met you in Tulane. having read a lot about you, having read your 3-volume textbook of ophthalmology, and back in the day, I want you to know, I used to know it cold. If you said volume 2, page 252, right side, what paragraph, I would have told you exactly what was there.
I believe you. I
Yes.
believe you.
But I do remember sharing, we did a lot of work, unfortunately, in Katrina. Katrina came and destroyed our close collaboration in Tulane, but we stayed friends since then. And more recently, he came to USF to visit us, and he shared his knowledge with all our residents and his blessings with our fellows. So, and you continue to inspire a whole bunch of retina surgeons in the country of India are logged in right now watching your YouTube presentation. And I specifically asked him to share his insights into his inventions, not to describe disease processes. A reason why is I'm hoping that some of the residents and fellows watching this talk by Dr. Peyman will get inspired to be an inventor, an innovator. Just not blindly follow what other people have done. Can we do better? The way the world is right now, can we improve it for the next generation, make it safer and better for the patient care is the question. And Dr. Peyman, you are a prime example of how to find a world and leave it better. And that's where I find you as my inspiration. Thank you for everything you've done, and thank you for accepting this invitation to talk. And on behalf of Anand Eye Institute, and on behalf of Telangana Ophthalmology Society, and on behalf of all the vitreoretinal surgeons, thank you very much. Now, some of the audience may have some questions.
Assalamu alaikum, Dr. Gholum, sir. So I want to ask you a question. A 19-year boy from Iran came to Europe and then went to US. So, and a lot of political changes in your country. So what kept you moving? And you changed the world of ophthalmology. In your family, there were a lot of changes, unrest in your country. So what kept you moving?
Well, I really don't really, as I said, as I mentioned, that we don't know in our life what we are made for. Very often we just limit ourselves to one thing, as Dr. Ella mentioned now. And from very beginning, I was interested in different things. I was interested in many aspects of the medicine, for that matter. I was initially wanted to become a cardiovascular surgeon, but kind of later changed my mind to ophthalmology. So it's just, I think one cannot, from my point of view, is not predetermined that I'm going to do this or I'm going to do that. It is really not the case. I have been interested in solving problems, and wherever I find a problem, I think about how to solve that. And that's maybe that will lead to one thing to the other things. And kind of, thanks God, I've been very successful about this now, but I can never do these things alone. I have to thank everybody who has helped me. I've been without the help of goodwill of Dr. Goldberg in Chicago and Dr. Culver in Tulane and other my colleagues. It's just collaboration with other people. I think that we are in a stage that we can never do really anything alone. It's just impossible. Now I have come to Arizona. I feel that kind of, okay, I'm pretty safe from hurricane, but kind of I don't have that lot to work with, despite that I have done enough supposedly, but I miss that still. I collaborate with other people, and tomorrow somebody else, I collaborate with a number of colleagues, my colleagues in Canada. Hopefully, if it's possible in future, we can collaborate with my colleagues in Hyderabad. So there is no reason why we should not be doing that. In reality, now with the communications and things that are available for us, kind of we are on the same page. So we can do these things much better than ever before. It was very difficult at the beginning. Even studying was complex. Now we can actually, everything is in our disposal. We just we can all we need is just to look at things, and if you want to work with somebody, and I think we need to collaborate with each other, because without that we can't move forward. The technology has moved significantly forward that we cannot keep up to date with that. And also in the ophthalmology, similarly, in every field the same way. But fortunately, I'm really interested in ophthalmology, but also interested in other fields. I'm interested in oncology very much. Not only oncology and on the eye, but also in the body. So I'm working, collaborating with my friends in Canada and Ryerson University, just we developed a new concept of managing the solid tumors in the body. And so it's just kind of, my interest comes from the subject, not necessarily that I sit down and think about anything. But I just also mentioned in this moment, without the collaboration of other people, it's just not possible. And I think it's so wonderful to be able to do that, and everybody benefits it. So thank you very much for your time.
Thank you so very much, sir, for your words of wisdom. Thank you.
Thank you.
Any other questions?
All right, thank you very much. I really appreciate that, and hopefully I see you soon again here in the United States, and also maybe one day, God willing, either or together.
Thank you, Gholum, on behalf of all of us. Thank you.
Thank
So on behalf of Anand Eye Institute and Telangana Ophthalmology Society, thank you for attending our session today, and I hope you will remember to bless Anand Eye into the future. I welcome Anand Eye into the next generation. Thank you. Gholum, I want you to know that you are a source of inspiration to generations of ophthalmologists. Okay?
Thank you.
You're the only genius that I've ever met in my entire life, a living genius. And I'm so grateful. I still remember the first day I met you in Tulane. Having read a lot about you, having read your 3-volume textbook of ophthalmology, and back in the day, I want you to know, I used to know it cold. If you said volume 2, page 252, right side, what paragraph, I would have told you exactly what was there.
I believe you. I believe you.
But I do remember sharing, we did a lot of work, unfortunately, in Katrina. Katrina came and destroyed our close collaboration in Tulane, but we stayed friends since then, and more recently he came to USF to visit us, and he shared his knowledge with all our residents and his blessings with our fellows. So, and you continue to inspire a whole bunch of retina surgeons in the country of India are logged in right now watching your YouTube presentation. And I specifically asked him to share his insights into his inventions, not to describe disease processes. A reason why is I'm hoping that some of the residents and fellows watching this talk by Dr. Peyman will get inspired to be an inventor, an innovator. Just not blindly follow what other people have done. Can we do better? The way the world is right now, can we improve it for the next generation, make it safer and better for the patient care is the question. And Dr. Peyman, you are a prime example of how to find a world and leave it better. And that's where I find you as my inspiration. Thank you for everything you've done, and thank you for accepting this invitation to talk. And on behalf of Anand Eye Institute, and on behalf of Telangana Ophthalmology Society, and on behalf of all the vitreoretinal surgeons, thank you very much. Now, some of the audience may have some questions.
Salam alaikum, Dr. Gholum, sir. So I want to ask you a question. A 19-year boy from Iran came to Europe and then went to US. So, and a lot of political changes in your country. So what kept you moving? And you changed the world of ophthalmology. In your family, there were a lot of changes, unrest in your country. So what kept you moving?
Well, I really don't really, as I said, as I mentioned, that we don't know in our life what we are made for. You know, very often we just limit ourselves to one thing, as Dr. Ella mentioned now. And from very beginning, I was interested in different things. I was interested in many aspects of the medicine, for that matter. I was initially wanted to become a cardiovascular surgeon, but kind of later changed my mind to ophthalmology. So it's just, I think one cannot, from my point of view, is not predetermined that I'm going to do this or I'm going to do that. It is really not the case. It was, I have been interested in solving problems, and wherever I find a problem, I think about how to solve that. And that's maybe that will lead to one thing to the other things. And kind of thanks God I've been very successful about this. But I can never do these things alone. I have to thank everybody who has helped me. I've been without the help of goodwill of the Dr. Goldberg in Chicago and Dr. Culver in Tulane and other my colleagues. It's just collaboration with other people. I think that we are in a stage that we can never do really anything alone. It's just impossible. Now I have come to Arizona. I feel that kind of, okay, I'm pretty safe from hurricane, but kind of I don't have that lot to work with, despite that I have done enough supposedly, but I miss that still. I collaborate with other people, and tomorrow somebody else, I collaborate with a number of colleagues, my colleagues in Canada. Hopefully, if it's possible in future, we can collaborate with my colleagues in Hyderabad. So there is no reason why we should not be doing it. In reality, now with the communications and things that are available for us, kind of we are on the same page. So we can do these things much better than ever before. It was very difficult at the beginning. You know, even studying was complex. Now we can actually, everything is in our disposal. We can already just to look at things, and if you want to work with somebody, and I think we need to collaborate with each other, because without that we can move forward. The technology has moved significantly forward that we cannot keep up to date with that. And also in the ophthalmology, similarly, in every field the same way. But fortunately, I'm really interested in ophthalmology, but also interested in other fields. I'm interested in oncology very much. Not only oncology and on the eye, but also in the body. So I'm working, collaborating with my friends in Canada and Ryerson University, just developed a new concept of managing the solid tumors in the body. And so it's just kind of, my interest comes from the subject, not necessarily that I sit down and think about anything. But I just also mentioned in this moment, without the collaboration of other people, it's just not possible. And I think it's so wonderful to be able to do that, and everybody benefits it. So thank you very much for your time.
Thank you so very much, sir, for your words of wisdom. Thank you.
Thank you.
Any other questions?
All right, thank you very much. I really appreciate that, and hopefully I see you soon again here in the United States, and also maybe one day, God willing, Hyderabad together.
Thank you, Gholum, on behalf of all of us. Thank you.
Thank
So on behalf of Anand Eye Institute and Telangana Ophthalmology Society, thank you for attending our session today, and I hope you will remember to bless Anand Eye into the future. I welcome Anand Eye into the next generation. Thank you.